Hi everyone, my name is Danielle. I'm a second degree dental student and this talk is about care of the free flap as part of the OMFS Survival Guide. We felt that free flaps weren't really taught about that much and it is something that you quite commonly see in Max Facts. So we thought we'd include it in the Survival Guide to give you guys things to look out for when monitoring free flaps and also problems that might arise and how you handle those. So quickly having a look at our aims of the talk, it's to understand what a free flap is and the common flaps that are used in Max Facts, to understand what parameters to monitor when you're the SHO overnight or on call and when caring for the free flap over the first few days post-op, and to be able to recognise problems with a flap and also how you manage these. In typical OMFS Survival Guide fashion, we're going to do this in case-by-case format. So this is case 1. So you are the SHO covering Max Facts and you have had a patient admitted to the ward the night before his surgery, and it's an 84-year-old male admitted with a T4N1M0 SCC to the left tongue base, and that's for surgical excision and reconstruction tomorrow. Now he has a past medical history of AF and hypertension, is on warfarin and atenolol and has no drug allergies, is a current smoker of 10 a day, doesn't drink alcohol and is retired. So what sorts of things when you're clerking this patient do you need to think about? So based on the history that you've got, you know that he is on warfarin for AF, so there should be a plan from the pre-assessment regarding his anticoagulation, and most likely that will probably be to withhold the warfarin the night before surgery, but this definitely needs to be checked in the notes. And then obviously you know he's hypertensive, so checking the blood pressure overnight is important. And he's a current smoker, so maybe prescribing nicotine patches or something like that will be important during the post-op period. Now, other things to think about when you are clerking a patient like this for extensive theatre the next day is doing a bit of background research on what operation they're having and whether there's any scans or anything that's needed pre-op when they're admitted the night before. Usually these will be done in advance, but it's just checking that the CT scan has a report, whether they need an up-to-date OPG, and just checking that these are accessible in the system because the surgeon won't see them the next day. Making sure they've had some recent blood tests. Again, these are usually done in the pre-op assessment phase, but just checking they've got, say, within the last couple of weeks, a full blood count using these liver function tests, coagulation, and potentially a group and save. And then obviously checking any other relevant tests for their past medical history. So in this instance, we would need an up-to-date INR in this gentleman to check that it's within range. Sometimes patients, especially with ongoing heart problems, might need an ECG when they are admitted, but this usually again gets done in pre-assessment. Similarly with lung problems, if they have COPD or anything like that, lung function tests are normally performed in the pre-assessment phase. Your job when they're admitted is to just prescribe the appropriate VTE prophylaxis and regular medications. Obviously in this day and age, ensure they've got a COVID swab ready for theatre and check that the consent form, if not signed, is prepped ready for the surgeon to go through it the next day. Okay, and they're all things that you should be checking pre-op for the patient. So moving on to the actual tumour that he has, so it was T4N1M0. So just to break down what this actually means, so TNM staging is used in the majority of cancers to stage it, to basically identify how severe the cancer is. So it's broken down into tumour, node and metastasis. So tumour is very much dependent on the size, as you can see there, less than 2 centimetres, 2 to 4 centimetres, greater than 4 centimetres. So this gentleman actually has T4. So that would be advanced local disease through adjacent structures, as you can see in this table. Moving on to N, so that's for nodal disease. So you can either have NX, which is that they cannot be assessed by the imaging or the biopsies that's been performed so far. N0 would be no node involvement, and then it progresses up from there with extensive node involvement. And then M is basically are metastases present or not, and that would be 0 or 1. So you arrive on shift the following night, and this patient has had their operation during the day and has had a wide local excision, left tongue base, reconstruction with a radial forearm free flap, and a left neck dissection. Now, what is a free flap? Some of you may have come across these before, some might be new to MaxFax and haven't seen anything like this before. So basically, a free flap is where you move tissue from one area of the body to another to reconstruct a defect. So in this case, this gentleman has had part of his tongue removed and part of the forearm has been used to fill that hole. Now, the important thing about a free flap is that it is moved with a blood vessel from the donor site. So in this patient, there will be a blood vessel from the forearm that goes up with that bit of tissue that then is connected to a blood vessel in the neck to keep that tissue healthy and ensure it survives. Common sites in MaxFax that are used are the radial forearm, so that's RFFF, so it's a radial forearm free flap. That's quite common, especially kind of tongue-based tumours, intraoral tumours. The radial forearm free flap is one of the most commonly used. You can also get the ALT, which is the anterior lateral thigh flap, so that's using a part of the leg. And then a fibular flap, so that's using one of the bones from the lower leg, is used as a reconstruction method for kind of mandible tumours, that sort of thing. And instead of taking a flap of tissue, as in skin, muscle, that sort of thing, it actually takes bone as well as the tissue. Okay, so the term free flap covers anything that is basically moving any part of the tissue, so whether it be skin, muscle, bone, with a blood supply up to the new site to fill the hole. Okay. And here is an example of one of those flaps. So this is a fibular flap, as you can tell by the plates that are on there to kind of set the bone in the right shape to fill the hole from the mandible. So picture A shows the excision of the area affected by the tumour. Picture B shows the flap from the leg, including the plate that you can see there. And then C is the whole reconstruction done. So you can see that there's a colour discrepancy between the flap and the skin, and that's something that you look at when monitoring the flap, but we'll come on to that in a little bit. So getting back to our case, the history's there on the left if you need to remind yourselves of anything. You're in charge of monitoring the patient post-op overnight on your shift. Most of the time, these free flaps go to ITU for a period of monitoring from anaesthetic perspective, so you'll probably be going there to monitor the flap and the patient. Okay, now what sorts of things spring to mind that you will have to monitor overnight? So hopefully you got some of these. We're going to go through each of these in turn in a bit more detail, but just as a quick overview, monitoring the patient overnight, obviously ITU will be monitoring them from an anaesthetic point of view. They'll probably still be intubated overnight or sedated. But the key things that you need to be looking at is the news score and keeping a check of their blood pressure and heart rate and things like that. Their nutrition, and we'll come on to that in a little bit. Their drain output. So a lot of these patients who have had extensive surgeries in the head and neck will have 1 or 2 or 3 drains in, and we'll go on to what you look at with that. The position of the patient, I'll come on to why that's important in a little bit, and also just generally reviewing the medications and any changes that have been made or any medications that you need to restart after surgery, things like that. Okay. So looking at the news score to start off with, obviously we monitor news scores in all of our patients, and this patient is no different. It'll probably be a more in-depth look at this because they're in ITU, so they'll get kind of hourly OBS rather than the 4 hourly, etc., that other patients may have on the ward. Okay, so the main thing with the news score is the blood pressure. Basically, this is to do with the survivability of the flap, and you need to maintain a good blood pressure to ensure that that flap and those blood vessels that have been joined together are actually working, and that the flap is getting blood to it. So we have to ensure that the blood pressure doesn't drop too low, which would kind of impact the blood supply to that flap. Okay, so ITU will do this fancy measurement called mean arterial blood pressure, also known as MAP, so MAP, and we're aiming that to be above 90, or the systolic pressure above 120. So ITU will probably be doing this overnight, but for any reason, if you notice it and they're not, you can give IV fluids, but this needs careful discussion probably with your second on call, because it's important that we don't overload the patient with lots of fluids, especially in that post-op period, because there is a lot of swelling that happens in their head and neck after a flap is done. So what we don't want is to cause even more swelling and things like that. So that just needs to be carefully monitored. There's also something that can be used in ITU by the medical team and by the ITU doctors called vasopressors. So they are drugs that specifically act to raise the blood pressure. So noradrenaline is one that's quite commonly used, and there's differing views on whether to use this in free flap patients or not. So if you get into that stage, it's something to discuss with your second on call, and then they would discuss with the consultant to see what they actually want to do. Okay, but the key thing that you need to be doing is recognizing this is happening and escalating that appropriately. All right, and then as well as obviously maintaining a nice heart rate and oxygen sats by giving oxygen if required, you need to check the temperature and maintain a normal temperature. All right, so that's like 35.5 to 37.5, ideally 36 to 37.5. Okay, so moving on to nutrition. Head and neck cancer patients who've had extensive surgeries, like in this case, are obviously not able to swallow and eat and drink in the normal way after the surgery for a period of time. Okay, so it's quite common that these patients will have an NG tube placed in theatre, which is something that you might have to get a chest x-ray for to check that it's in the right place after the operation. So the way that you do that, you can see on this chest x-ray. So you're looking that the NG tube goes straight down, bifurcates the carina, which is basically where the trachea separates. So obviously we don't want the NG tube to be in the trachea going into the lungs. So if it goes through the bifurcation of the trachea, you know that it's not there, because obviously it would go in one, either the left or right side. So it would continue straight down, and that would mean it was in the esophagus, going all the way down into the stomach, and you're looking for that tip of the NG tube to be in the stomach. Okay, obviously any problems at all with this, just ask the ITU team. You're not expected to be able to do this straight away, but this comes with a bit of practice, okay? And if you feel unsure at all, always ask for help, because this is something that we don't want to get a mistake on, because if this patient does end up getting feed through this NG tube and it is in the wrong place, that feed would go into the lungs and cause an aspiration pneumonia, and the patient will get very unwell. So it's not something that we pass up lightly, and if you are having any doubts or any questions about this at all, please raise it to either a medic or your second on call. Okay. So usually the feed actually commences about 24 hours post-op, and the patient will be monitored kind of on fluids or things like that overnight, immediately post-op. It just depends on the specific post-op instructions. Okay, but the main thing to check from nutrition point of view is the NG tube being in the right place on that first night post-op. So moving on to drains. Now a drain is basically an instrument, like you can see in the picture, with a almost container. We call it a vac container, so it's a vacuum, and then it's got that plastic tube which goes all the way up to inside the patient, normally through their neck or one of the other wound sites where they've been operated on during the day. Now, drains are quite common in head and neck cancer patients. They can have 1, 2, 3 drains in, so it's important to monitor them overnight, especially that first night. On that first night, it's important to check the drains for blood, basically, because one of the most worrying things on the first day post-op is if there's any ongoing bleeding in the neck, and that would present itself by filling that drain with blood. And as soon as that happens, you need to be calling your second on call, because most likely that patient will end up going back to theatre to be opened up and to stop the bleeding that's going on. I've seen it a couple of times and it's very, very obvious. So if this was a drain coming from the neck would become very tense and swollen, and that drain would just fill up with maybe 100, 150, 200 mils of pure blood, and then that is basically an emergency, because obviously it's at a risk of restricting the airway and things like that. So as soon as there's any concerns regarding that, it's worth a call to your second on call, and then most likely the consultant to go back to theatre. Okay, so there's a number of types of drains that can be used. So there's passive drains. Now these are normally used in your kind of submandibular abscesses when you have an infection and an abscess, and you take it to theatre and drain it, and then you pop a little corrugated drain, which is basically just to keep that space open, and it's on a free flow, so it's not connected to anything. It's just basically there to let the rest of the pus leak out of that cavity. And then you've got active drains, like in this picture, which is we use quite commonly in MaxFax, a vac drain, which is basically a vacuum which aids to kind of suck out that fluid from that space, okay? And then the important thing is to get a 24-hour drain output. So as your job as the night SHO, it would be to go up at, say, 6 o'clock in the morning, check how much has been in the drain over the past 24 hours, and usually it'll be in for a couple of days, maybe 5 days, and will be removed when there's about 20 mils in the drain after 24 hours, okay? But that decision's made by the consultant. Your job is basically just to monitor that drain output and report back to the team with the 24-hour number of how much is in that drain. Sometimes these drains can devac, which is quite a problem, but just escalate that to the team, especially in your guys' instance in the first few weeks. Escalate that to the team, and then they can have a little look at it and see if they need to adjust the drain in any way. All right. So next, moving on to position, and by this I mean head position. So in head and neck cancer patients who have received a free flap, you've got the blood vessels that are connected from the donor site, so from that forearm, and that's connected to a blood vessel in the neck. Now it's quite important to keep these vessels still to maintain the blood flow to the flap, okay? And surgeons will write in their post-op instructions to be nursed at, say, 45 degrees, head neutral position. Now this is just to make sure that the flap has the best chance of survival, and those blood vessels aren't constricted by turning the head one side or the other, or any blood flow is compromised to the flap. So it's always best to check the post-op instructions to see if there's anything specific related to that patient, but usually it's a neutral position of the head, as can be seen in this picture. Looking at medication. So going back to our case, we obviously know that he's on warfarin and atenolol as regular medications, but specific medications related to getting a free flap, as this patient has received, would be antibiotic cover, which should have been started in theatre, and those antibiotics continue whilst the drain is in, usually for about a week, okay? And then another medication common in head and neck cancer patients after they've had such extensive surgery is some IV steroids, so usually dexamethasone, 6.6 milligrams, and they normally get 3 post-op doses. So they may have had one in theatre, or they may receive one on a night time, and then 2 the following day. So it's just important to check that those are prescribed. Obviously, always check the operation note in case there's any changes to that plan. So they may say more steroids or no steroids, etc., etc. Usually it's 3 doses post-op, but it's always important to check. Okay. And another thing that we need to think about in this patient is the anticoagulation plan. So it's unlikely that they'll be starting warfarin the day of the surgery after he's just finished, because there's a high chance of bleeding, but it is important to discuss that in the ward round or with the ITU team as to the plan for restarting that anticoagulation. It may be that they cover the patient with high dose kind of dalteparin, tinzaparin, whatever the low molecular weight heparin is used in the trust until they can restart on warfarin. That's something that you would discuss with the ITU team or the MaxFax team during the day. Don't worry about sorting that out by yourself overnight. Okay. So, up till now, we've been monitoring the patient. Okay, so all of those things are looking at the patient from the end of the bed, assessing their observations, nutrition, position, drain output, and medications. Now, you have to do a thorough assessment of the flap itself. Now, these are called flap observations, and it's something that you'll become very familiar with in these head and neck cancer patients, because basically post-op it'll be done every hour for the first 24 hours and then onwards from there. So it might go down to 2 hourly and then 4 hourly, etc., etc. Okay, but this is a very key skill in MaxFax, because any problems with any of these need to be raised and may need to be actioned on fairly quickly. Okay, so there's 3 things that you look at when monitoring a flap. 1 is the Doppler, 2 is the colour of the flap, and 3 is the consistency. So we'll look at each of these in turn. So, looking at Doppler. So Doppler is basically an ultrasound test that uses high frequency sound waves to measure the amount of blood flow. So in this case, we're using that to monitor the blood flow between that vessel that was in the neck already with the vessel it's been connected to from that tissue that's been moved. Okay, so as you can see in that little picture, there's basically 2 types of Dopplers. You can have implantable, which is where there's, as you can see in the picture, a little plastic cuff around the vessel. So you can see just a little bit up from that is where what we call anastomosis, where the connection is between the 2 vessels. So that plastic cuff is on there and monitoring the blood flow, and that is connected to the machine, which is in the picture next to it in the top right hand corner of the slide, and that machine gives off a light and sound signal to let you know that the blood flow is flowing through that vessel. The other way to monitor this, so the implantable ones are the most commonly used now, but if for any reason that isn't working or you're having trouble with that, there's also a manual Doppler option. Okay, so that uses a machine very similar to the photo in the bottom right corner, but instead of the little sort of triangle connector at the top there, it's actually kind of a long thin pole that you use, and you can place it on the free flap itself, so in the tongue if it's been used to reconstruct the tongue, or something like that, to try and find where that vessel is, to have a little listen to the blood flow. This will be explained, if you need to do this will be explained to you, you'll be taught how to use this, but it's more just so you guys are aware that there is actually another way of monitoring it rather than the implantables if there's any issues with it. Okay, if this does need to be used, the surgeon normally pops a little stitch on the flap where the point of the biggest sound is using the ultrasound machine, So at least you have something to guide you as to where that output of sound should be using that manual Doppler. All right. And then the final things that you need to look at with monitoring the flap is the colour and consistency. So looking at this picture, you can see the tongue and then you can see the flap that's been stitched to it, which is more of a peachy colour. Okay, now this is the colour of a healthy flap, and when you press on the flap, you should get a good capillary refill. So basically, you put a little bit of pressure on the flap, it should turn a bit white, and then within 2 or 3 seconds it should come back to the colour that the rest of the flap is, so that peachy colour. Okay, and the consistency, it should be soft, because if not, if it's starting to feel quite firm and solid, that could be a sign that there's an underlying problem with the blood supply and it's getting a bit congested with blood because that blood isn't flowing away. Okay, so this is a good example, this photo is a good example of what the flap should look like immediately post-op. Okay, so coming back to our patient, the patient recovers very well on ICU and the flap observations have been stable. So you've been checking the Doppler output and that's had good sound and light, and the colour and consistency has been the same. So that soft pink flap, and he's been moved to the ward for ongoing care about 3 days later. And he recovers well and then is discharged within the week with normal follow-up. Okay. Now moving on to case 2. So once again, you are the SHO covering Max Facts overnight, and this time you have a 69-year-old female admitted with T3N2M0 SCC to the right tongue base for surgical excision and reconstruction. So going back to our earlier slide, you know that the tumour is 3, the nodes are a 2, and there's no metastases. And she has a history of previous alcohol excess, no regular medications, has an allergy to penicillin, smokes 40 a day, and is retired. So operation wise, she receives a wide local excision of the right tongue base, reconstruction with a radial forearm preflap, and has a right-sided neck dissection. So you're in charge of looking after this patient immediately post-op. So as you know from the previous case, she'll be going to ITU and will most likely be sedated or still intubated for a period of time post-op. Now, whilst assessing the patient overnight, you've been doing your hourly flap obs, but about half an hour after the latest set of observations, you're called to ITU because of a problem with the flap. So what sorts of things might you be thinking of when they say a problem with the flap? So you want to be going back to basics, back to what we said before. So you want to be looking at the Doppler signal, the colour and consistency of that flap, and that will tell you whether there's something going on or whether it's just a positional thing, and the head has maybe moved slightly and is slightly altering the signal that's coming out of that Doppler. So it's very important that you look at all of those 3 things, which we'll come on to in a second. Okay. So you go to examine the patient, and when looking at the flap, you see this. There's no Doppler signal, so there's no light or sound coming out of it. The flap is obviously discoloured from that peachy colour that we saw in the other case of the healthy flap. There's a very prolonged cap refill time, so when you put a little bit of pressure on there, there's no blood coming back to the flap skin, and it's quite cold to touch. Okay. So how do you manage this? The Doppler signal isn't there, the consistency isn't right, and the colour isn't right. Hopefully you'll realise that this isn't a problem that you can fix on your own, and the first thing you need to do is call for help. So call your second on straight away, and they'll probably phone the consultant for further discussion and to make a plan. A failing flap is one of the max fax emergencies and a reason why patients go back to theatre in the middle of the night, because any time wasted, you're just causing more problems in the future. All right. So it's probably wise at that point when you're discussing with your second on, obviously they'll give you guidance as well, but contact the anaesthetic team to let them know that this is happening, and that the patient might be going back to theatre within the next hour or two, so they can come and prep the patient. But in the meantime, whilst your second on call is coming into the hospital, you continue your acute management of maintaining those observations, making the patient nil by mouth for theatre. So if, for example, this was 2 days post-op and they were having their NG feed, you would stop that NG feed immediately and then continue the nil by mouth plan for theatre. And then do the usual kind of admin work. So you'd add them to the theatre list, make sure all the drugs and things are sorted for theatre, and prep a consent form for when the consultant arrives. Okay. So why does the free flap fail? Now, the most common reason is thrombosis. So that basically means a blockage within that connection between the vessel from the tissue that was transferred and the vessel in the neck that it's attached to. So that anastomosis, it's basically a blockage within that that's stopping either the blood reaching the flap or the blood leaving the flap. Now, the most common type of blockage is actually in the venous system. So that would be a blockage stopping the blood from leaving, which is why in these pictures you can see it's quite swollen and bruised. It has like a dark bruised appearance, and that would be a sign that the blood is basically getting stuck in that flap, causing lots of swelling, and then that in turn is blocking blood coming to the flap, okay, therefore causing flap necrosis, which means that there's no blood getting to the flap, so the likelihood of that flap surviving without intervention is very, very low. Now, the flap obs that you do overnight and during the day are there to detect the early stages of this happening, so that things can be done, the patient can be taken back to theatre to try and salvage that flap as best we can, because what we want to avoid is the patient having another massive surgery where they have to take another flap from another area of the body, because the first operation was obviously the best for the patient, so that if that fails we have to almost go with the second best option. So we always want to try and save the flap that we've got. So that's why flap obs are so important, and that any changes that you notice, no matter how small, always discuss it with your second on call, just so you can raise it, and then the team are aware and can monitor it, say when you're not there, when you change your shifts or anything like that, because flaps are, it's so important to keep an eye on these because they can go wrong very, very quickly. Okay. Now, that brings us to the end of the talk. Thank you so much for sticking with it. I know there might be a lot of new terms in there, but caring for the free flap is a really vital skill for working in max fax, especially in those units who do a few head and neck cancer cases a week. You could be monitoring maybe 3 flaps overnight, so it's a really important skill to learn. Okay. There's a couple of resources that you can use to further your knowledge in this, and just to go over what we've kind of touched on in this talk. So there's the Show Me app, which is available with not just about free flaps, but about kind of max fax in general. There's also the book The On Call in Oral and Maxillofacial Surgery, which is available, which is a really good resource, covers kind of ward work, A&E work, and covering free flaps and things like that. And there's also a paper that you can look at for a bit more detail if you really want to, but that's all there for you. All right. But thank you so much for joining us. Please see the rest of the pre-recorded crash course for starting in Max Facts. There's lots of other talks there about drug prescribing and how you interpret bloods and things like that, so please watch them if you haven't already. And obviously any questions about this talk or any at all, or feedback, we always welcome feedback, please get in touch with us via our email address, or there's more information on our website and Instagram page. So keep in touch and let us know if you have any questions or feedback. Thank you so much.